Head and neck cancer, or HNC, encompasses a diverse group of malignancies affecting areas like the oral cavity, oropharynx, larynx, hypopharynx, and paranasal sinuses. Globally, it stands as the seventh most common cancer, demanding a sophisticated multidisciplinary approach. This complexity stems from varied causes, intricate anatomy, and the significant side effects that can arise from treatment. Mastering these critical details is essential for effective patient care and improved outcomes. A crucial insight into head and neck cancer is how HPV status sharply divides oropharyngeal squamous cell carcinoma into two distinct diseases. Human papillomavirus type 16, or HPV-16, drives 60 to 70% of oropharyngeal cancers in the United States and Europe. These patients tend to be younger, with a median age of 54, and are often non-smokers. A unique presentation for HPV-positive cases includes asymptomatic cystic neck masses, where the primary tumor in the tonsils or base of the tongue can be quite small and difficult to detect. In stark contrast, HPV-negative head and neck squamous cell carcinomas are strongly linked to traditional risk factors, such as tobacco and alcohol use. These patients are typically older, with a median age of 66. The prognosis also differs dramatically. HPV-positive oropharyngeal cancers boast a much better 5-year overall survival rate, reaching 80% for locally and regionally advanced disease, compared to a range of 25 to 60% for HPV-negative disease. Understanding these distinctions underscores the critical need for a precise diagnostic approach when a new or persistent neck mass presents in adults. The workup typically involves a flexible nasopharyngeal laryngoscopy followed by either a fine needle aspiration or a core biopsy of the suspicious neck mass. Importantly, all specimens must undergo testing for HPV, with immunohistochemistry for P16 protein serving as a highly sensitive surrogate marker for an active HPV infection. Staging then proceeds with a CT or MRI scan of the head and neck, often complemented by a PET-CT scan to accurately assess for regional and distant metastases. Once diagnosed, the treatment strategy for head and neck cancer is carefully tailored to its stage and location. For early-stage HNSCC, defined as Stage 1 or Stage 2, the primary goal is curative intent, often achieved through single-modality therapy using either surgery or radiation. For oral cavity cancers, surgery is generally the preferred option to prevent the significant risk of osteoradionecrosis of the mandible, a severe complication of radiation. Conversely, for laryngeal and pharyngeal cancers, definitive radiation therapy is often favored. This approach helps to preserve the vital organs responsible for speech and swallowing, which are crucial for a patient's quality of life. However, when HNSCC progresses to a loco-regionally advanced stage, meaning Stage 3 or Stage 4, a more intensive multimodality therapy becomes necessary. Treatment options include initial surgery followed by adjuvant radiation with or without chemotherapy, or definitive concurrent chemoradiation for non-surgical cases. High-dose cisplatin administered every 3 weeks alongside radiation has proven to be the most effective agent, significantly improving survival compared to radiation alone. Adjuvant chemotherapy is also incorporated into post-operative radiation regimens for patients exhibiting high-risk features, specifically positive surgical margins or extranodal extension from a lymph node. Remarkably, the landscape of therapy for recurrent or metastatic head and neck cancer has been revolutionized by immunotherapy. Today, first-line therapy in this setting is immunotherapy with pembrolizumab, used either alone or in combination with chemotherapy. The pivotal KEYNOTE-048 trial established that pembrolizumab in the first-line setting dramatically improved overall survival compared to the previous standard of care. For patients whose tumors express PD-L1 with a combined positive score, or CPS, greater than or equal to 1, pembrolizumab monotherapy presents a viable option. However, for all patients, regardless of their PD-L1 status, combining pembrolizumab with platinum and 5-fluorouracil chemotherapy offers a superior option compared to the older regimen. Further underscoring the shift in treatment paradigms, checkpoint inhibitors are now the standard of care for HNSSC that has progressed even after platinum-based chemotherapy. In these challenging cases, single-agent immunotherapy is the preferred approach, offering both improved efficacy and a more favorable side effect profile when compared to traditional chemotherapy. Studies like Checkmate 141 demonstrated that nivolumab significantly improved one-year overall survival compared to other single-agent therapies. Similarly, the Keynote-040 trial confirmed a survival benefit for pembrolizumab in this specific clinical scenario.